Good afternoon, members. Good afternoon. I call this meeting of Human Services Policy to order. Members, please take your seats. I will note that we do have a quorum. Representative Novotny, have you looked at the minutes and would you like to move them, please?
Chair Fisher, I have read the minutes and I do move them.
Very good. Representative Novotny moves the minutes from February 13th, 2023. Are there any questions or amendments? Thank you. Hearing none. All in favor of approving the minutes from February 13th, 2023, signify by saying aye.
Aye.
Opposed? Motion is adopted. The February 13th, 2023 minutes are approved. Members, we have one bill on our agenda today and a series of presentations on the opioid epidemic and our policy responses. First, we'll be hearing House File 1486 from Vice Chair Frederick. Vice Chair Frederick, I see you're at the table. Would you like to move your bill?
Yes, Mr. Chair, I move to refer 1486 to the Health, Finance, and Policy Committee.
Very good. I also understand you have an author's amendment. If you'd like to explain your amendment, please.
Thank you, Mr. Chair. The A1 amendment clarifies that in the scope of practice for an LADC, what we are looking to do is for them to be able to continue in the work that they're doing post-internship. And what it does is saying that it has to be in the same location as their internship, even if they have not been licensed yet. And that it also is not just a continuation of the internship, it is actually a paid position at that point.
Very good. This is to get the bill in this shape that the author would like. Any discussion on the author's amendment? Hearing none, all in favor of the author's A1 amendment signify by saying aye.
Aye.
Opposed? Motion carries. The author's A1 amendment is approved, so we will go to House File 1486 as amended. Vice Chair Frederick, please explain your bill.
Thank you, Mr. Chair and committee members. We've heard a lot of this already in this committee, so I'm going to be super brief. What this bill does is it's focused on substance use disorder treatment. I'd like to thank Representative Baker for his collaboration on this bill. And it is a piece of the SUD work that's going to be introduced this year. But it is the parts that hopefully do not have a fiscal cost. And so it kind of focuses around what I had just kind of talked about with the amendment, that someone who is completing an internship continue to do the work of an LADC while they're waiting for that full licensure. Yeah, I'm actually just going to turn it over to the testifier to be even more brief, Mr. Chair.
Awesome. Thank you, Vice Chair Frederick. Good afternoon. Welcome to the committee. Great to see you again. If you'd like to introduce yourself, let us know who you're with, and please start your testimony.
Thank you, Chair Fisher. My name is Brian Zerbis. I'm here on behalf of March, representing their Government Affairs Committee. I also work for North Star Behavioral Health, a substance disorder organization in Minnesota. So continuing on the overview that Representative Frederick was talking about, for former students, what the section is looking at doing is be able to support the workforce for substance disorder programs in Minnesota, have continuity of care, and then have this 90-day window where a former student or once an intern completes their internship, that they can continue in the program while they're waiting for licensure with the Board of Behavioral Health and Therapy. We had worked with BBHC on this language as well. Should I keep going through the rest of the sections?
If you'd like to go ahead, Mr. Zerbis.
Okay, thank you, Mr. Chair. Section 2 is updating HIV training standards. The language deletes some obsolete language, as well as requiring the commissioner to outline HIV training content. Section 3 is regarding expanding options for withdrawal management programs. Currently, withdrawal management programs have to have a supervised living facility license, which Class B license, which is for non-ambulatory people. This would expand to also add Class A licenses, which are for ambulatory individuals. The last, Section 4, is a technical change regarding client record documentation that would allow documentation for significant events to be done within 24 hours rather than on, quote, the day of the event. That concludes my testimony, Mr. Chair.
Very good. Thank you, Mr. Zerbis. Is there anyone else from the public that would like to testify on House File 1486? Hearing none, we will move to members. Members, are any questions or comments, and we'll start with Representative Baker.
Hey, Mr. Chair, thank you. And I should know this, Representative Frederick, but is there a cost to this bill?
So the intention.
Vice Chair Frederick.
Sorry. Thank you, Mr. Chair. The reason the provisions that are in this bill, this is the bill that we pulled out of the bigger package with the intention that there would not be cost associated with this.
Representative Baker.
Mr. Chair, and where's the next step at this? Is it to the general registry so we can get it passed, or where are we going with this? Because we're passing bills fast this year. This is an important one to go with. And if there's no fiscal note, I'm just sorry, I'm ranting, but what is the next step?
Next step, Representative Baker, is it's going to the Health, Finance, and Policy Committee just to make sure that there isn't a cost to it.
Okay.
And if there isn't, I would hope that'd be one that we could pass forward. I'm looking at Chair Knorr. If Chair Knorr would like to make a comment on it.
Thank you, Mr. Chair. I think Representative Becker is also in the Human Service Finance, so we'll have more conversation.
We will.
All right, thank you, Mr. Chair.
Could this be on the consent agenda potentially?
Maybe, and again, this is important stuff, and we pulled it out. And again, I give credit to Representative Frederick for doing this really well. We pulled it out for a reason. We want to get this thing going so that our folks in the field can start hiring people, getting this thing going. We are doing some lightning speed stuff around here. This is one of those that we should do as quickly as possible to get it in the field. So again, I just appreciate both chairs being in the room and hearing this, and thank you, Representative, for doing this. So thanks.
Thank you, Representative Baker. Next, I've got Representative Backer, and then after that, I have Representative Edelson. Representative Backer.
Yeah, thank you, Mr. Chair. My question is, one of the frustrations I hear as an EMT, as over the last many years, we have to do more and more paperwork. My question is, does these document changes in this bill go far enough so the providers are focusing on treatment and less on paperwork? That's my question.
Representative Frederick, or if you'd like to phone a friend. Mr. Zerbis.
Thank you, Mr. Chair. Representative Backer, the one piece of Section 4 on client record documentation requirements is a very small piece. The other bill that we're hoping to bring forward has additional documentation pieces to it. But for this bill, it's just that one piece on the documenting significant events within 24 hours.
Representative Backer.
So, and I appreciate that. So will there be less documentations or about the same so they can focus on treatment? That would be my question based on what your anticipation, Mr. Chair. And
Mr. Zerbis.
Mr. Chair and Representative Backer, yes, it is our intention that this will allow staff the time to work with clients and then have a longer window, that 24-hour window, to be able to document that event.
Okay. Yeah, and so if I may understand,
Backer.
I'm sorry, Mr. Chair, thank you. I see where you're going. I appreciate that because it gives them that longer time period. Thank you.
Thank you. Next, Representative Edelson.
Thank you, Mr. Chair. Thank you, Representative. This is a great bill. I guess I just want to know how many people will actually this impact? So how many of the professionals will be able to practice that are being limited right now?
Mr. Zerbis?
Thank you, Mr. Chair. So there's 430 roughly licensed programs in the state. So this would impact any of those that host internships for that piece. For the client record documentation part, that would impact all of them, the programs and the licensed staff within those programs.
Representative Edelson?
Thank you, Mr. Chair. But we don't know how many interns this isn't, like exactly how many. Do we have like an account? I'm just curious if there was I know you said 400 potential facilities, but we don't know how many interns.
And we'll also go to Vice Chair Frederick first.
Thank you, Mr. Chair. So to kind of, there's not necessarily an exact way to measure this because there's not a way to know how many people moved on to other jobs because they weren't able to continue the work, right? Because if there's a delay a month or 2 months before they can get their licensure to practice as LADC, there's not a way to know for sure how many of them just got jobs elsewhere. And so this, versus if they were able to just to continue doing the same work in the same place at that same time. And so this is just one of the many ways that we're trying to address the workforce issues, saying, hey, if this is a barrier, if this is causing somebody to go get a job anywhere else, no matter what the job might be, because they're not able to continue doing that work between their internship and just waiting for a licensure. The intention of this is for them just to continue doing that same thing in the hopes that they can, we can continue to grow the field in the LADC community.
Representative Elson.
Mr. Chair and Representative, thank you so much. I mean, as a clinical clinician myself, I understand the importance of being able to just be hired. And so I support the bill. I was just curious if we knew, like, ultimately this is going to inject, 100 drug and, but that's fine. Very supportive. Thank you.
All right. Not seeing any other questions. Vice Chair Frederick, will you offer closing comments and move your bill?
Thank you, Mr. Chair and committee members. It's relatively small in the scope of what we're trying to do with this bill, but hopefully it will be impactful. And I appreciate the committee's support, and I renew my motion to re-refer 1486 to the Health and Finance Policy Committee.
All those in favor of referring House File 1486 as amended to the Health, Finance, and Policy Committee signify by saying aye. Aye. Opposed, nay. Motion carries, and House File 1486 as amended is on its way to the Health and Finance Policy Committee, and I will now be turning the gavel over to Vice Chair Frederick as I'm presenting in another committee.
All right, thank you. Our next item of business is to receive an update on the Minnesota's opioid epidemic response policy activity. We'll be hearing presentations from the Opioid Epidemic Response Advisory Council, the Department of Human Services, and the Office of the Attorney General. We will start with ORAC and the Representative Baker. Our presenters will be taking questions throughout their presentations.
How do we hit button? Just a button here? Boom, 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 I see it. There we go. Thank you. Good.
Representative Baker.
Hey, thank you, Mr. Chair and members. So this is a moment for me to sort of reflect back on a bill that many of us here have worked on, and actually Lexi next to me was actually part of helping this bill come along too, and she can give her background when she gets to that point too, because this is important. You're gonna hear a brief update about the ORAC committee. You'll hear more about this. ORAC. Another acronym, the Opioid Epidemic Response Advisory Council. This was created back in about 2019. It was worked on a couple years before that. So especially for the new members here, it's important to understand the journey that we've been on, what the Minnesota has done, and it leads the country in a lot of these discussions because we've actually had an advisory council with enormous authority to grant out money to nonprofits, to profits, to counties, to municipalities that have ideas to help people in substance use disorder issues, and a lot of things around that. We came up with this idea of tapping into the license fees. We collect around $15 million a year from the pharmaceutical companies that sell everything from a regular medicine that's not an opioid related. Opioids pay a higher fee if you want to sell them in Minnesota. If you sell a lot of opioids in Minnesota, that's a large fee. So total, we bring in about $13 to $15 million. And I think I'm going to try to do this. So the short PowerPoint that we have is a moment that happened back in 2019, I think. And again, Lexi was probably right around that area. But this is Senator Eaton and I passing the bill at one of our stops. And Senator Chris Eaton, like I, lost a child to this horrible disease. And so it helped us drive this mission of doing something different in Minnesota and to bring a way that we could collect and raise money on our own without coming back to the legislature and keep fighting like everybody else is doing every 2 years that we see here. And it was a lot of people working on this. It was a lot of wins, a lot of heartbreak. There was some things, and today just happens to be my son's birthday. Dan would have been 37 years old today. And I became a dad today, 37 years ago, and I'm doing a lot of this work with ORAC, and I'm currently the chairman of the ORAC Council, and I'm super proud of the work that we've done. It is a lot more work than I ever imagined, and we knew when we passed the bill this was going to be a lot of work because we didn't want to screw it up. So to members that were here 3 years ago that helped us pass the bill, thank you. To the new members, this is how this should work, and this is important to get it right, and how you pass legislation in a bipartisan manner with both bodies working together. Again, my co-partner in this thing was Representative Liz Olson. In the Senate, it was Senator Eaton and Senator Rosen, and I just will never, ever forget those legislators that had to cut through a lot of stuff to get it here today. So we're just going to talk about this a little bit. I talked a little bit of how we raise our money. Again, we have an ongoing funding source. Once a year, the Board of Pharmacy turns over the monies they collected on this licensing, turns it over to MMB. Half of that money goes to the counties for child protection services, because we knew then that's where we need a lot of help for parents that were sick. There's also a large chunk that goes to the Native American community. We've got $300,000 that goes to Results First. There's other slices and dices. Again, some of it goes to DHS, who's our administrator, who helps pay for the staff that we need to make this thing work. Again, I'm just kind of flying by the seat of my pants because there's a lot to cover in a short amount of time. We do a lot of collaborations with ORAC. We have MDH at our table, we have DHS, we have the Department of Corrections, we have County Public Health, and we all focus on what are we doing around the state of Minnesota to get this right. It's not just about opioids, it's about substance use disorder in general. And we have meetings all over the state of Minnesota. We've been up north to, Bemidji. This Friday is our next meeting. We're going to be up in Mora at a center. What's the name of it again?
I will get back to you on that.
Forgot, sure, but it's a special place that helps mothers in use issues that are helping them have their families there and deliver the babies, and this is a great place in Mora, Minnesota. So I forgot the name of it, but Sadie's also on our board, and this is important. So again, we have 19 voting members on this council. We took very careful thoughts about who should be on this council. We did not want something too big. So we've got the Native Americans represented. We have 2 seats for them. We have state agencies. We have providers. We have doctors that are specializing in addiction medicine. People that are in recovery. We've got 4 legislators, again, 2 from each body and 2 from each caucus. We have law enforcement there. And so we have a very well thought out ORAC council. We meet mostly almost every month. And our next work is to get our next RFP ready to go, request for proposal, because we actually do we do that funding ourselves. These 19 members get to decide where the money goes. It doesn't come back to the legislator. We intended that. We didn't want it to get all screwed up. So they did it, and they trusted us to do this right. And I think we're doing a lot of good things to make sure we don't drop the ball on this. Obviously, it's personal to a lot of us. And again, as we still build up our team and still build up our policies, and how do we properly get these RFPs out in a bigger manner as it's coming forward? Because it's getting bigger, because also ORAC is taking 25% of the settlement dollars coming into Minnesota that has been agreed to on national scales from the folks that were part of the greediness, folks that were part of the letting things go the wrong way, and they knew it was wrong, and now they're paying a price. So 25% of that is coming to the ORAC committee, and then 75% of that is going to our local counties. And Lexi is going to kind of share what we've been doing and how we're doing it. And I will tell you also what's unique from my perspective is the challenges of getting all this money out right. We've talked about fraud and abuse. We've talked about this a lot. I think it comes up at every single one of our meetings. We are not going to get this wrong. It's not to say we couldn't make a mistake, but we're trying to do the very best we can with our scoring process, with who is it, how the follow-up is. My asking as a chair, Lexi, our director, to get her eyeballs on some of these groups. She's got very good grant writers behind the scenes. And as a legislator, I get to work very closely with DHS on this area under the Behavioral Health Division. And I will tell you, they are doing a great job with a very stretched team. They are tight. And I see it firsthand. So there are times when I will tell you, I see it because I see the other side because of ORAC. And I want to share that with you because it's nothing we haven't heard. They're stretched. We push them hard. Sometimes Lexi and I don't agree, like, I need it tomorrow, and she's like, I can't do it tomorrow. Well, we work through that, but it's important stuff that we're working on. Here's just our RFP focuses right now, our prevention and education, our treatment training. I mean, we're getting people in the schools that are training youth and enhancing the continuum of care, safe use of opioid medications. There's a lot of stuff going on, and at this point, I want to turn it over to Lexi, and she can introduce herself, Mr. Chair, and her journey to get here as well. And it's kind of unique that we actually hired her. I was really pushing hard we needed a director because it was coming at us too fast. It was too hard for the staff that was already there, and we got really lucky and found Lexi here. So if you wouldn't mind, Mr. Chair, I'll have my testifier start.
Sounds good. Please welcome to the committee, and please introduce yourself and proceed with your testimony.
Thank you, Mr. Chair and members of the committee. It's an honor to be here with you today, and I appreciate that. My name is Lexi Reed-Holtum. I am the State Opioid Response Program Director for the Department of for DHS in the Behavioral Health, Deaf, and Hard of Hearing Division. That's a bit of a mouthful. As Representative Baker said, I have had the privilege of working with you all to get here, to work on this legislation in the past, and it is just by my good fortune that then I'm also hired by the department to fulfill on the work itself. I'm a person in long-term recovery, and I also have lost loved ones to opioid overdose death. So it's personal and professional for me. Thanks for letting me share that. I wanted to give you an overview of our accomplishments thus far. We have just roughly over $15 million that we have distributed through the RFP process to 52 grantees. So we have 52 unique providers who are working in the 4 category areas that Representative Baker already informed you of. Of that, we have a very great geographic area covered. We are statewide, about $4.6 million are going out across the state. In the metro area, we have 5.9. Just in Greater Minnesota, doing only work in Greater Minnesota, we have 2.8. And then our tribes and tribal reservations are doing just over $1 million worth of work. And unspecified, meaning it crosses all categories for the most part, is $680,000. Of that, one of our largest areas of focus has been treatment, as well as workforce development. In addition to that, we've done quite a bit of Narcan or naloxone distribution at $2.9 million. And I wanted to call out just a couple of the grantees that we have been funding so you have an idea of the work that they're doing. Change the Outcome. That one Representative Baker spoke to already. That is a school-based program that is led by Colleen Ronnie. And what they're doing is they're taking peers who are in recovery, and those peers are sharing their stories with high school students, middle school students to support pathways to recovery for them. It is a very effective peer-based program. We also have MRC, Minnesota Recovery Connection, is doing harm-based peer recovery training and supporting that across the state. We have RS Eden, who is working with our homeless and our prison populations. So these are just a few of the many that we could talk about today. We have all areas and all of the categories are really doing some great work, and I'm happy to give you more information on any of that should you wish to have that.
Mr. Chair, just I'll say a couple final things because this is just an overview, and we've got some other folks who are going to speak to us as well. Narcan, naloxone, if you don't know what it is, come talk to me about it. I've actually got some in my office I want to give to you. If you haven't seen the little narc box in front of my office, if anybody around here ever needs naloxone because somebody has gone under or you don't know what's going on, I have it right there in front of my office. If anybody needs some, if you know somebody that might need it, I have it both from the Steve Rumler Foundation. both the nasal and the intermuscular type of injection. So we've got that to give away. And those, again, a lot of those grants come from what our work is here at ORAC. And just, you know, you'll see some harm reduction stuff on here too. We've learned a lot as ORAC too. We've learned that we need to be a part of the solution about breaking down the stigma of addiction. And that fentanyl strips are okay to hand out to people, and it's not meaning that they're going to continue to use, but if they are going to use, then let's make sure they're using safely. And I'm not embarrassed to say that like I used to be maybe 10 years ago. I didn't understand it as well as I do today. So we're coming a long ways on this. Again, I'm super proud of the work that ORAC has done. We partner with the counties that need help and maybe collaborating with all the money they're getting now, and ask your counties what they're doing with this. You should do that. Some of the large cities, over 30,000 also, are receiving these settlement dollars, and they really have the ability to do a lot of things at their own about what they're doing about their recovery services, their addiction services. That's the thing that they're working on too. You heard one bill today that might make a difference in workforce. We're doing a lot of things to help encourage people to stay in it. If we can help them by providing more services, more people, we'll do it. And again, we've got some good rules that we work with around. So our council is hardworking. They're very dedicated. It's the right size. It's led by a great group of people that are working really, really hard to get our grants out. And our next grant will be similar to, this one will be our biggest one ever. It'll be probably north of $20 million. And we're going to try to do it on an annual basis, give or take. It's going to be about, I don't know, was it 16 million from the settlement, 16 to 18 million? I think it's 18 million. And then it's about 6 million for the licensing fees that we have left to use. So we're going bigger, and it's creating more pressure on the grant writers. I also want to give a huge shout out to our Attorney General's office for helping us work through the processes of working with our counties and our cities on that complicated memo of understanding that we did about a year ago now. And so it was a lot of work, and I know we're going to hear from them as well. So, Mr. Chair, that's a quick ORAC update. Happy to answer any questions, or we can just wait for another time.
Thank you, Representative Baker and Director Reed-Holton. At this point in time, I will see if there's any member questions. Representative Edelson.
Thank you, Mr. Chair. And Representative Baker, I remember when I was first elected, and I read about your son, Dan, and having a good friend that lost her daughter from carbon monoxide poisoning, completely something different, but just knowing what that's like to watch what happens there, I just want to thank you for all of the work that you've done here. And I know Senator Eaton and her daughter, Ariel, that she's making very proud too. So I just, thank you. I just want to say thank you. And then I see you.
Thanks.
Not seeing any more questions. We'll move on to the next presentation. Thank you. Next up is a presentation from the Department of Human Services on opioid use disorder and opioid epidemic response policy. Christy Graham from the Department of Human Services. Please introduce yourself for the record and proceed with your testimony.
Director Graham, you can hit the escape and then the next presentation on there.
Thank you, Mr. Chairs and members. For the record, my name is Christy Graham. I'm with the Department of Human Services. And let me just get the right presentation up for you all to see. Wanted to provide some information for the committee to take a little bit of a deeper dive into some of the governor's budget recommendations and also some of the policy proposals as they relate to substance use disorder broadly, but also the opioid use disorders as well. So this is definitely a priority topic for Governor Walz, for Lieutenant Governor Flanagan, and hopefully you'll see that reflected in our budget priorities. Many of the strategies that we're using to support people with opioid use disorder have that broader impact on substance use disorder. So you'll see that throughout the presentation. I also want to note that we have a new state addiction and recovery director in Minnesota that was established last year. And so the department has been working very close with Mr. Drucker on all of our budget recommendations and are really looking forward to continued partnership there to make sure that we're co-creating ideas that are really going to be responsive to the issues in the community and addressing some of the provider concerns as well. So starting out with the first slide, this is just a representation, and you can see that we have some of the worst opioid overdose disparities in the nation. And so again, this is something given the disparities you'll see reflected in the governor's budget in terms of prioritization of proposals that are really aiming to move the needle and reduce those disparities. In Minnesota, we have a white mortality rate of 10.7 per 100,000. For opioid overdose, and so that's one of the lowest rates in the nation, contrasted by Black Minnesotans who are 3 times as likely as white people to die from opioid overdose, and Native Minnesotans who are 10 times as likely than white people to die from overdose. So those are pretty staggering numbers, and we've seen year over year. We've got the Department of Health here and many others who can really speak and dig into that data, but we continue to see increases in overdose deaths, and we continue to see increases in disparities as they relate to overdoses. So I wanted to point that out. It's one overdose is too many. These are preventable deaths, and so that's what we're all working toward doing and making sure that we're targeting resources where they're most needed. So the next slide, I just wanted to kind of give a depiction of when we're thinking about how to put together, the governor's budget proposal. When you look at change pages in our budget book, it looks very linear, but it's actually more cyclical the way we think about ideas and how we put all of these ideas together into a package. And so here you can see sort of a reflection of how we think about the continuum of services as they relate to substance use disorders and opioid use disorders. Beginning sort of at the top with prevention, and then moving to harm reduction or preventing harm, and then connecting to care, which is really all about connecting to those clinical treatment services. Within this particular topic, we're looking at a few different things. So in particular, how do we improve access to clinical SUD treatment services? How do we improve the quality of those services? And how do we make sure that they're culturally responsive and culturally appropriate? And then recovery supports is an important part of the continuum. We need to make sure we're investing there in aftercare type supports, peer services. So you'll see that as part of our governor's budget recommendations. And then, of course, social determinants of health. So it's really hard to stay sober or to, even want to get sober when you don't have a place to lay your head, when you don't have housing, when you don't have the means to put food on the table, healthy food on the table for yourself and your family, when you're living in not just poverty, but extremely deep poverty. And so we know, and we've heard from the provider community as well, that these are issues that we need to address in tandem with some of the treatment policy interventions. And then lastly, we're always wanting to make sure that we're evaluating what we're doing from a policy perspective, that we're looking at the data, looking at the outcomes, understanding what's working, what isn't, what are some of the emerging trends, what are the best practices, and what do we need to reassess in terms of what we're doing in our system to support people. And so a lot of this work happens with our partners at the Department of Health, who have a database for the opioid use disorder issues. And at DHS, we're looking to build out some of this in the work that we do. We already do some of this reporting, particularly through our SUD 1115 demonstration waiver. And we'll talk about that a little bit more. And then at the center of all of this, the way we think about our how we develop balanced and appropriate budget for this area is thinking about the person as a system. We're a bureaucratic system, and that's not a bad thing, but we always have to kind of take a step back, check ourselves, and this is something that we're really making an effort to do throughout all of our budget processes, is understanding how is the person experiencing the system, what is the person's lived experience, and what kind of inequitable outcomes might a person be experiencing. So thinking about the first category, prevention, we have a few items in the budget that I wanted to touch on today. So we've got an increase in funding for our school-linked behavioral health grants. This came up in committee recently. I'm trying to remember, Mr. Chair, if it was this committee or Chair Nor's committee. But I think many of you have heard about our schooling behavioral health grants. These are grants that we partner with providers, mental health providers, substance use providers in the community, and they co-locate professionals right in the school so that children and youth can have their needs met. These grants also help support family units more broadly, as well as teachers and educational staff. A few years ago, the legislature modified the scope of these grants. They used to just be called schooling mental health grants. Now they're called schooling behavioral health grants, and so we do include an intentional focus on substance use disorder, and that's reflected in some of our RFPs. So that's an important investment to really intervene early and understand where there's needs arising, even if it's a mental health need that could eventually turn into a substance use disorder if not addressed early. We'd also like to look at establishing a public awareness campaign to really get more information out in the community about, just some of the concerns around misuse and abuse. In particular, we've heard from some communities around the need to educate youth. It's just a scary place out there. There's access to opioids all over the place still. There's not enough access to naloxone. So we really want to make some efforts to get more educational information out into communities. We'd also like to, this is a little bit outside of the prevention bucket, but we'd also like to make sure that as part of this public awareness campaign, people know how to access treatment. We've had a big shift. It's happened over a long period, and it's a good thing, where we changed from counties or lead agencies as what were called placing authorities to people being able to just directly access treatment, just like you or I can just go to the doctor, any doctor that we want, and get treated based on what the diagnosis is and what our preferred treatment options or preferred treatment course is. And so we want to make sure that people understand you don't have to jump through hoops anymore. You don't have to go through the county. You don't have to go to the lead agency. You can find any provider who provides comprehensive assessments to get treatment. We also want to look at reducing some barriers for our family treatment programs. So these are important programs, and we don't have many of them in the state. They serve whole family units where a mom or potentially a dad is in treatment with their children. Obviously, these are important resources for people to prevent out-of-home placements, prevent involvement in child protection systems. And the proposal in the governor's policy bill this year around this is related to childcare requirements at those facilities. So right now, people aren't able to access all of the childcare they need. So they, I believe, are able to access 3 hours of childcare per day, unless the facility is a licensed childcare center, which it's my understanding most of these are not. So we are in our budget proposing to make that flexibility so that if someone needs more than 3 hours of treatment services a day, they can get commensurate childcare to deal with that. I will note that this topic and others, as I walk through the presentation, are things that we are talking about as part of the governor's revised budget. And so that obviously doesn't come out for a bit, but we are hopeful and have been working really hard to look at additional resources that we're able to target for opioid use disorder in that revised budget. And then thinking about harm prevention or harm reduction, sometimes as it's referred to. A few things that we're working on as part of our budget this year, and again, there could be more in the revised budget as well, but we want to make sure that we have better access, improved access to our withdrawal management programs in the state. I believe we have 9, or maybe that's an overestimate, withdrawal management programs right now across the state, and really there's such a need given the overdose issues and just given opioid use disorder in general. We really want to make sure that people have access to that medical treatment that they can get to safely withdraw. That's also a great place for when you're have had maybe not a good experience and you're needing and wanting to withdraw to actually get resources to access treatment. So withdrawal management centers oftentimes, in addition to all of the important clinical and medical work that they do, help people connect with the resources that they need, whether that's treatment or even peer recovery services. So we've got a proposal to increase or provide some startup grant funding and capacity funding for current programs to really try to build out that system more. There's also overdose prevention grants that are Currently, I think they're funded through 2024. And so these are grants that help programs purchase naloxone, as was described in the previous presentation. And we want to make sure that those grants are ongoing. So we're adding ongoing funding for those grants as part of the governor's budget as well. And we're also looking at establishing a new Project ECHO. So Project ECHOs are sort of provider learning communities where providers can get together and really understand best practices. And they happen across multiple disciplines in the health field and maybe beyond that. But we would really like to look at adding a new one around opioid treatment programs and how can we really improve and make sure that our opioid treatment programs and providers are attuned to the best practices. They're understanding what's working at some of the more high-performing opioid treatment programs. So we've got an investment for that as well. And just to clarify, opioid treatment programs are those programs that that dispense and prescribe methadone, which is not available in a clinic setting. They also provide other medications for opioid use disorders like Suboxone and other medications, but they are primarily known for improving access to methadone. So the next slide, kind of in the Connect to Care bucket, the first bucket on access. A few things to note here. We've got a proposal that will allow hospitals, federally qualified health centers, or FQHCs, and rural health clinics to be able to provide assessments. These are called comprehensive assessments that allow people to access SUD treatment services without having to jump through the hoops to get a 245G program license. So right now there's some barriers to them being able to do that. There are options, I believe, for professionals in private practice to be able to do assessments at those settings, but we've heard that this is a barrier, and people oftentimes might end up in a hospital, for example, in an ER with an opioid-related accident or an alcohol-related accident, and in that moment, we've heard from both hospitals, from managed care organizations, that it's a really beneficial thing to be able to offer that assessment to someone right in that moment. We're also looking at additional or ongoing funding for a kind of online platform for people to be able to find SUD programs, find mental health programs, understand if they have beds open, understand if they do inpatient services or outpatient, to understand if they perhaps serve communities, specific communities like the LGBTQ community, or if they're culturally specific. We really need to make sure that people have that information, people have that access at their fingertips. And we do some of this now. We have a program called Fast Tracker. But I think we've heard from people, we've heard from the community that we can do more. Fast Tracker has some state funding, but we'd really like to make sure that there's ongoing funding and some requirements around enhancements of that service. And then lastly, something really exciting, we are excited to be requesting some administrative dollars to help us put together and really understand what a medical assistance benefit for people who are in jails and prisons would look like. So this is something that historically has not been allowed. The Centers for Medicare and Medicaid Services have, I believe it's called the Inmate Exclusion Act, where MA dollars have not been, generally speaking, there's some exceptions, but generally speaking are not allowed to be used in jails and prisons. And as a result, people are getting sort of spotty access to behavioral health services. So in some places they might be getting mental health services or SUD services. In some settings they might not be. One of the things that's been really alarming that we've been looking at with our colleagues, particularly at MMB, is the overdose rate for people when they're exiting jails. And it's extremely significant, and really making sure that people can get access to those medications for opioid use disorders when they are in jail or in prison is really something that would benefit many populations. So we're excited to start looking at this. This would take a demonstration waiver, so it's a lot to stand up, and that's why we're asking for some administrative resources to really figure out what that benefit would look like and who would be eligible. So far, there's one state that's been approved to do this, and so we have one state to learn from, but it is a pretty innovative idea, and we're excited about that. When it comes to quality, our kind of cornerstone of our SUD reform package and improving quality of SUD services is related to requiring that all treatment programs adhere to American Society of Addiction Medicine standards, that they also adhere to the referral agreements, the evidence-based practice requirements, that they've got outreach plans in place, and that they're really providing that person-centered, culturally specific, evidence-based care. We know that, that this type of care works, and we know that providers want to be providing this kind of care. And so we just need to work together kind of as a state to help support that transition. In 2021, the legislature passed a bill that was supported in the governor's position as well that required our residential providers to adhere to these standards by 2024. And so we have that effort underway right now. It's going well. We've had to, of course, do a lot of intentional stakeholder work. We've got office hours that we do with our provider community. And we've heard sometimes when things aren't working well, and we've made modifications to make sure that we're rolling that out well and in a way that works for the provider community. And that really helps them to improve the services that they're able to offer. And so this proposal would require that also outpatient programs will be required to meet these standards. And so that would be under the governor's proposal, we're looking at 2025. And I think one of the gifts of looking at and reforming the SUD system so it's more person-centered is that it also reduces a lot of administrative burdens on providers, and it reduces that paperwork. We heard some of that conversation earlier today. So there's parts of being able to make this transition that were brought forward by the provider community and are now made easier by it. So for example, there are hourly requirements for residential treatment where providers have to either provide 30 hours a week if they're doing high intensity treatment, 15 hours a week if they're doing medium, and 5 if they're doing low. And those hours are just arbitrary. They really aren't based on a person's need. And it just doesn't make sense to require a person to have a set amount of hours for treatment services. And so we'd like to, as part of this, we're going to be able to remove those hourly requirements from statute and allow people to provide the care that the person needs based on their assessment and their preferences. We've also got some changes around simplifying our assessments, our comprehensive assessments, so that we're able to more holistically support people. So some changes that we've been working with both the SUD community and the mental health community on, looking at how we can streamline diagnostic assessments to also include comprehensive assessments, so that if a qualified practitioner is doing an assessment and someone has both SUD and mental health needs, they're able to sort of check off those boxes and complete that assessment in one place and not have to, do 2 assessments, or someone wouldn't have to go to 2 different providers to get that done. We're also removing a few of the required components from the individual treatment plan and really focusing on the treatment plan being more person-centered and culturally responsive. And then lastly, we currently now have weekly treatment plan reviews for every person, and that's a kind of across the board, no matter what your need is and no matter what program you're in. And so what we want to do as part of this proposal is change those treatment plan review frequencies to be really contingent on what your need is. So generally speaking, I believe it's around 14 days instead of every 7 days, and then it goes down based on a person's need. And then the last kind of bucket of the connecting to care that we wanted to talk about today is around making sure that we've got culturally specific and culturally responsive services to people who are accessing substance use disorder treatment services. And we know that there are disparate impacts on communities of color. And so this is a really important cornerstone of our proposal as well. So we've got increased funding for our cultural and ethnic minority infrastructure grant. We call that CMIG sometimes for short. And that's a grant that helps pay for supervision costs, which are oftentimes hard for providers to meet for people who are both trying to become a mental health professional as well as trying to become a licensed alcohol and drug counselor, or a LADC. And so those are really important grants. They're successful grants. We have ongoing evaluations that really document all of the successes there, and we'd love to continue them and expand that work. We've also got an increase in funding for provider supervision grants. These are newer grants that were passed last year in 2022, and there is a focus on underrepresented communities with these grants, but there's also a focus for rural Minnesota where people have disparate access to services as well. A few things related to the 1115. This is our demonstration waiver that was, we haven't gone in depth on that today, but just kind of a very brief preview of what that was, is that waiver was really announced by CMS at the beginning of the opioid epidemic. And it was something that CMS implored states to look at of what can you do to reform your system to make sure that you're providing evidence-based practices to really address this, this terrible epidemic that we're experiencing. And so that's was really the kind of the impetus behind that particular federal authority that we've been talking about some today. And so one of the things we'd like to also do in kind of that demonstration federal authority way, similar to providing treatment services in jails and prisons, is look at how we can add traditional healing to our medical assistance program. So we've got traditional healing grants that we'd like to extend funding for. They're very successful grants that go directly to our tribal nations as well as urban American Indian communities. And so we're really looking forward to doing some work with our Native community and really studying what this traditional healing grant could look like. Here again, I think there's one other state that has been approved to do traditional healing under medical assistance or Medicaid. We've also got a few changes that we brought forward in past years to the ORAC, which we heard a lot about today. So we'd like to make sure that each tribal nation has a seat on that council. We'd like to make sure that African American and Black communities are represented as well as urban American Indian communities. And we want to make sure that they continue the good work that they're doing around dispersing that money to culturally specific and culturally responsive programs, making sure that at least 50% of the funding goes to those kinds of initiatives or programs. And then sort of rounding out the recovery continuum, we've got recovery supports. And so we have a pretty significant proposal around peer recovery supports, both on the mental health side and the substance use disorder side. And so one of the kind of core pieces of this proposal is codifying some of the best practices in statute for recovery community organizations to really preserve the integrity of that model. These are grassroots organizations. They provide non-clinical services, which are really important for people when you think about people who are in vulnerable positions, experiencing substance use disorders, maybe being involved with justice involved or being involved with perhaps child protection or family court, and oftentimes being in treatment programs where there are mandatory reporters, which is an important part, obviously, of recovery and healing. But to be able to have someone that's a peer that you can trust, that you can say anything to, that can really help you work through some of the issues that you might not be able to tell or feel comfortable telling a clinician, is really a proven and effective method to help people support sustaining their recovery. And so we'd like to make sure that our recovery community organizations are maintained in the state with the integrity that they have right now. And we'd also like to make sure that we've got some funding to those recovery community organizations, so ongoing grant funding for them to provide services that might not be covered by MA. Also, as part of this proposal, we would like to expand MA vendor eligibility for peer recovery services to counties. So counties have come to us and indicated that they see a need, a place where they could really help, in particular with people who are involved with the justice system, to be able to provide those peer recovery services in those spaces. And then maybe lastly on this slide, I'll touch on integrating standards. So we've got we have three kinds of peer services. We've got family peer services, mental health, and recovery. And we're really focused on the mental health and peer recovery services for this proposal. But they have very different standards. They have different eligibility requirements, different testing requirements, different CEU ongoing training requirements. And we really want to make sure that it's easy to become a peer. We need more peers. MMB has done a report on this not long ago, that we really need to expand access to peers. So by integrating some of those standards, streamlining them, we hope it'll make the service more accessible, and we hope to increase access. And then we also hope that our peers will be better equipped to work with people who are experiencing co-occurring disorders. So a few things quickly on evaluation and social determinants of health. So in our governor's proposal, we do have funding for a data and evaluation team. We do, as I mentioned, some of this work through our 1115 SUD demonstration, where we're required to do quarterly reporting and to post that reporting online. But there is a lot of information that we get and that providers submit that is oftentimes difficult to provide to the public in a format that is understandable, and that in a format that helps us really both at the department and for providers and for policymakers to really know what is the right policy intervention. And so we've got some funding for in behavioral health, housing, and deaf and hard of hearing for this data and evaluation team to be able to provide better access to data and to be able to provide some ongoing evaluation. We've also got a proposal to make sure we're collecting in a more transparent way information around outcomes at opioid treatment programs. We want to understand what's working when people are accessing sort of complementary services like individual counseling along with the medication that they're getting there. We want to make sure that we can track what's working and what's not, and be able to provide guidance and policy recommendations on that level. And then on the addressing social determinants of health, there's quite a few investments in the governor's budget. So we've got increases to our general assistance program, which is a program that serves people with disabilities or disabling conditions, oftentimes people with substance use or mental health issues. And that rate, similar to MFIP, has not been increased since 1986. And so the program's intent is really to provide a bridge to make sure that people who are experiencing that very deep level of poverty are able to meet their basic needs and live in dignity until they can get on Social Security or another support program. And so there is a requirement with general assistance that people have to apply for Social Security. So this is really a bridge program, and it's just not sufficiently meeting people's needs right now. So we'd like to make sure we're making some investments there. We'd also like to take a look at the felon drug testing requirements that are requirements for, I believe, counties and tribes right now, where people with felonies on certain cash programs are required to be drug tested. Counties are required to do some kind of drug testing. And when people do test positive for a toxicology screen, oftentimes either their benefits are reduced or they're completely kicked off of those programs. And we just see that as an overly punitive approach to substance use disorder, given the opioid epidemic right now in particular, and want to make sure that instead of taking the supports that people really need that help them maintain some kind of semblance of wanting to be in recovery and striving for that, and instead just make sure that counties and tribes are offering resources to people when they do test positive, and making sure that that's an optional thing for counties to do. We've also got several investments in housing. So one of them that I'll note today is a presumptive eligibility for people who are exiting correctional facilities. So most people who are exiting correctional facilities are eligible for our housing support program, which is a program that serves, again, people with disabilities, people with disabling conditions, older adults. Who meet certain eligibility requirements, income eligibility requirements. And so what we're seeing right now is a lot of people are being exited just directly to homelessness, either on the streets or doubling up with people. And they, in fact, are eligible for housing support, but it just takes a few months to get them approved. So we'd like to make sure that people exiting have 3 months of that housing support while they get the papers in order to get everything to get their housing support extended, or if they've been able to obtain employment during that time, that would be great, and then they can be able to pay for housing on their own after that. And then lastly on this slide, we've got investments in a couple of our grants that support kind of homelessness outreach and also supporting people who are maybe precariously housed, who have mental health issues or co-occurring disorders. We want to make sure that those grants continue. They're very successful grants. And we want to make sure that people who have an standalone SUD diagnosis are also able to access those. And then this last slide, it's kind of small, but hopefully members have it online too. You can see the various governor's budget recommendations, many of which I covered today, and their page numbers. So if you've got questions or you want to dig into a proposal, you have those resources available to you. And of course, we're always here for questions.
Thank you, Director Grom. There's a lot of information there. So at this point, I turn it over to questions from members. Looks like everyone's processing the information that they just got. Representative Finke.
Thank you, Chair Frederick, and thank you for your presentation. I just was wondering if you could speak a little bit specifically to your work with the LGBTQ community. I heard you reference it, but I didn't notice it in the presentation, especially among your cultural and ethnic group work. And just a little bit of the background being that, more people than ever are identifying as a part of our community. And we know that our community has higher rates both of use and overdose. So I just want to make sure that we are being thoughtful and specific in how we're treating our community.
Director Grom.
Mr. Chair, Representative, that's a great question. I think we do have some struggles in really obtaining data to fully understand the impact in that community, and that's something that we need to work on. I will say with the Cultural and Ethnic Minority Infrastructure Grant, one of the things we're doing as part of the governor's policy bills that I didn't mention today is codifying some of our grants in law, because we need to make sure that we've got program integrity and that we're administering our grants as they were intended by the legislature. And so there's a variety of grants that we're going to codify and specifically explicate, the outcome measures and the eligible populations. And Representative Edelson will be championing some of that work, I believe. I think that's in your policy bill. And we are codifying requirements that the LGBTQ community is part of the eligible people that are serving that community are eligible providers or grantees under that grant program. And so that's one thing I could offer, but I could definitely get back to you and check with our team as well to see what else is afoot. I know that there's a lot of work that I'm not always privy to at my level.
Representative Finke.
Yeah, just one quickly, because I appreciate that, and I would love to hear more from the team, or if there are opportunities for us to do more. Right at the start of the continuum of care is prevention, and one of the ways that we can prevent people from ending up in the SUD space is by no longer kicking them out of their homes, no longer stigmatizing them at schools, right? Recognizing that the affirming values of who young people are helps prevent them from using in the first place. So I just want to keep that in mind as we think about drug prevention. We're also doing that work all the time in many other arenas. So thank you, and let me know how I can help.
Representative Keel.
Thank you, Mr. Chairman. You mentioned, Ms. Grom, you mentioned that there was some transitioning from incarceration. And I'm wondering, we don't hear, or I'm not in any committee that hears about how much treatment we do. I'm guessing that there are quite a few people that are incarcerated that have had some kind of drug SUD problems, whether it's small or, whatever level it is at. But it has come to my attention that much of that is not done until we're looking at somebody who's incarcerated is leaving. And then we deal with their drug problems. And then I'm wondering how much time after that, we're talking about housing, how all that happens in such a short time, because as we've heard, being addicted to different types of drugs take quite a bit of adjustment, and that's an awful lot of change in one's life after being incarcerated, you know, and the choices that have to be made at that point.
Director Graham.
Mr. Chair, Representative Keel, so if I'm understanding your question, I think you're asking how do we coordinate so that people, when they're exiting corrections, they not only have access to housing, but they have access to treatment services or other services to keep them stabilized?
Mr. Chair, the other question I would have is, are we doing that before? You know, how are we preparing them long before they are being released?
Director Graham.
Mr. Chair, Representative Keel, I think that's an important question. I do know that Department of Corrections does a fair amount of substance use disorder treatment. I don't have the specific data on how much they do, at what frequency they do it. You know, it might be sort of an inconsistent. I'm not sure how much consistency there is there. It probably depends on a variety of factors and populations and people, whether or not they want treatment. That's something we can look into and get back to you on. I will say that we have a program called the Bridging Benefits Program, and it's a program where our housing division actually collaborates with the Department of Corrections to identify people when they're at high risk of recidivism. And so it's not while they're in the midst of their incarceration, it's toward the end, so it's not exactly what you're getting at, but I do think it's important for you to know about that work going on. And so DOC comes to us and they say, these are some folks that are at high risk of recidivism, and we send essentially kind of care coordinator, case manager type people out. This is another very lean program at DHS. I think we maybe have 2, maybe 3 staff, and a couple of them are temporary. And so we are asking for more funding for that program too. But it's showing really promising results to be able to go and meet with those people and to not just get their housing set up, but to get mental health services set up, to get SUD services set up. And so the hope is to continue doing that work and to do more of it. I think also with the study on providing behavioral health services in prisons and jails, hopefully that once implemented will provide more consistent access to those services. I think the way that that California has modeled that benefit is that it's happening sort of maybe not throughout all of incarceration, but at the end during a few months prior to release. So those are, I mean, we definitely have ideas and would love to talk to you more about what you're thinking in that area.
Representative Keel.
Thank you, Mr. Chair. I just have been exposed to some different conversations. First of all, things like a family approached me on their frustration with not dealing with the drug issues as that person was going into a sentence. The thing that startled me was Dad called the other day and said, my son has now said he's pretty used to the schedule and the lifestyle that a incarcerated person is living. And I think this child, not a child, a man, but he is close to being released. And so their concern was, is he ready to go out? And then the other one is there is a gentleman in Hudson, Wisconsin that provides housing for incarcerated people that are released and trying to help them stabilize their life and get the help they need because of that transitioning period. You know, families might not embrace someone coming out. And then the drug issue, whether it's alcohol or drug, the issues that are a problem. Because I was naive and thought that when you're in prison, there was no access to drugs. And I have since learned that that is not true. So there's, unfortunately, as hard as our law enforcement works in prison settings, that's pretty available. So thank you.
Representative Edelson.
Thank you. Thank you, Mr. Chair. And Representative Keel, I just wanted to address that. I was on public safety the last 4 years, and I value your question because I completely agree. There's been a lot of work where, like, think if somebody has a DWI or multiple DWIs, they're incarcerated. They're an alcoholic, right? And then we're not dealing with that, and there has been limited access in prisons to exactly what you're saying. So I value and echo that. I know that the commissioner of the Department of Corrections is working on that. You know, one thing I will say is during our last session, or maybe it was the one before, and I apologize that we're deviating it a little bit, but it's kind of connected. But we had driver's licenses that people were able to gain access to while they were in prison, and that helped with that discharge process because so many people that were incarcerated didn't have a driver's license. They were released, then they were trying to play catch up to get a job, and to get a job, they needed to have a driver's license. And so I know that there's a lot of work where they're trying to holistically look at somebody incorporating, but I would be curious too. So we should follow up on what's happening now.
All right, we will have one more question, then we'll go to the next presentation. Representative Kieran.
Thank you, Chair. To the points we're bringing up, I know we've deviated a little bit from DHS, but for those looking for more information on the discharge plans process from corrections and what we provide for folks, stay tuned for a public safety hearing tomorrow on House File 824 that addresses some of those issues. You know, things like accessing the care that people might need for mental health services, making sure they have the prescriptions they need when they're leaving prison, which could include prescriptions to help battle addiction. So just wanted to make sure to mention that in this space, you know, we don't always hear, you know, with the other committees when we have some intersections going on, but just wanted to make folks aware that we're working on that too in the public safety space.
What number was that?
824.
All right, thank you for the flag. We are going to keep moving. Thank you, Director Grom. Next up is a presentation from the Minnesota Attorney General's Office on national opioid settlements. I don't know who's first, so whoever is, just state your name for the record and proceed with your testimony, please.
Thank you, Mr. Chair. Good afternoon, members. My name is Eric Maloney. I'm an Assistant Attorney General from the Minnesota Attorney General's Office. Make sure I got the right PowerPoint slide here. I believe we do. Just so members know, we sent the presentation version yesterday that has since changed, so your printouts may be outdated, but what's on the screen is current, and we can get you a new copy if you guys need one. And it's the same content, just different ordering. So apologies for that. So let's get started. So I'm going to kind of be the history portion of this. I'll walk through kind of what's happened in recent history with both our office, the settlements, and some of the legislation. Then I'll hand it off to my colleague Evan to talk about this kind of new wave of settlements. That's the kind of round two of all this work. So you all already heard from Representative Baker. He talked about the 2019 legislation, landmark bill. I think, you know, we all applaud him and the other authors for their work on that. And he talked about ORAC. You know, that was a kind of key function of that bill, and also the opioid fees. The piece that ties into our office and into our litigation is that legislation set up a special opioid fund, a special set-aside, where if that fund didn't exist, our litigation recoveries would just go into the general fund to be appropriated for anything. And this set up a special set-aside saying, you know, we're going to dedicate these funds, have ORAC spend them to address the crisis and to not just be spent on, you know, kind of anything. And that was, I think, a really, you know, it was an important goal for our office and a really, you know, key feature of this bill back in 2019. So after that bill passed, a few years later, this is, I'm casting my mind back, it was summer 2021, we announced that we had settlements with the three big distribution companies. It's the kind of three pharmaceutical wholesale companies. These are huge, giant corporations. It was those three companies, and then Johnson & Johnson, who was a manufacturer of opioids. We joined those settlements in summer 2021, and the cities and counties, and we'll talk about kind of how they came into this, but they then joined onto those settlements in about a year ago, in January 2022. Those settlements will bring in over $300 million into the state of Minnesota. because of the work we did on this, we have earned the maximum amount under the settlements. We'll get into that, but there's a structure about variability and payments, and I think we're pleased to sit here and say that we've earned the kind of full amount that we could earn. It's going to come in over 18 years, so it's a big number, but it will take a while to kind of trickle in, and it's all going to be designated for abatement of the opioid crisis. So far, with the payments we've received from last year, we've gotten about $63 million, and there's obviously more to come, but that's what we've gotten so far. So I mentioned there being a kind of bonus structure and payment variability in the settlements. That ties into this concept of what the companies call it global peace. So it's a kind of convenient term to use. Basically, these settlements are predicated on companies wanting to resolve all litigation across the board, both from the state side of things, from state government, from our office, and from cities and counties who also sued right alongside us. So they kind of wanted everyone to kind of come to the table, get on board, and give up their lawsuits in exchange for this settlement. And that included both those who had filed lawsuits and those who hadn't filed but still could file. They kind of wanted to have the decks be cleared with just no future litigation. And states that were able to achieve that kind of have lawsuits taken care of, have those who didn't file suits release their claims, got the maximum numbers under the settlements. So when this happened, our office tried to sit down and think about, how are we going to achieve this with Minnesota? This is somewhat unprecedented. Like, there's not really a roadmap for this. Our typical settlement that Evan and I would work on just involves our office on behalf of the state. Doesn't involve cities and counties usually. So it was kind of a different group of people and a different dynamic than we're used to. So we spent a lot of time and talked to a lot of different people, sat down with local government groups, a lot of state experts, including Representative Baker, ORAC council members, various agencies. We talked with tribal representatives, other community members, and kind of brought everyone to the table to talk about, we have a lot of money coming into Minnesota. We need to figure out kind of how to spend it and how to split it between the state and cities and counties. And we put together two different groups of people to work on that, both kind of a public health expert-focused panel that met first in fall 2021. And then we had what we called the signers table. But it was basically a group of both kind of stateside and local government officials who actually put together the formal document to set up the plan of what we're going to do with the money. And that plan is what we call the MOA. It's the Minnesota State Subdivision Memorandum of Agreement. A nice bit of legalese, but it's kind of a contract or agreement kind of between the state and local governments about what we're going to kind of jointly do and what the plan is with the spending of these funds. The big feature of the MOA was the 75-25 split. So the local governments get 75% of funds directly, and that includes all 87 counties and all cities over 30,000 person population, all cities that filed suit, there was a few of them, and then all cities with public health departments, which I believe is coextensive with the population number. So that's who gets 75%. 25% goes to the state. And that goes to ORAC to be spent on abatement through their work. There was also a use of funds provision in there, and that kind of came from the national level. There was a list of programs and ideas of how to spend funds. So we put that in there, and it kind of, the agreement kind of, it does cabin what the funds can be spent on, but it's a long and broad list, right? Because there's a lot of different things that can go into, treating this crisis. So that's also in the MOA. We did that process throughout fall 2021. By the end of December, by the end of the year, we had the document finished, sent it out to cities and counties for joinder, and we got all 87 counties, all cities over 10,000, and almost 50 cities under 10,000 joined the MOA. So I think at the end of the day, it was a good process, and we got pretty good results in that, with a pretty quick turnaround, getting that level of sign-on from local governments was, I think, really, really great. So what followed after that, as you can tell, this is a complicated multi-step process. So after we got the MOA done, we got the sign-on and joinder from the local governments. was we needed new legislation. And this was contemplated in the MOA, that it was necessary for us to, they weren't, gigantic changes to state law, but, the bill at this point was 3 years old and we had new settlements. So, we had some kind of tweaks to make it work with the new framework. The bill did three main things. The first is that it unlocks the settlement funds. I won't go into the details on it, but essentially this let us, as settlement funds come in, it let ORAC, do their work and spend them as they came in, and not have them kind of set aside to wait for future triggers. The bill also changed state law to allow for the 75-25 split. There were a few reasons why that split wouldn't work under the old law, so this changed things to kind of accommodate this new 75-25 split and have funds flow directly to cities and counties for them to spend. The bill also included a claims bar. So the claims bar was essentially to ensure that we got global peace, got maximum money by basically saying, all claims that could have been brought by cities and counties, we're going to, deem them basically wiped out against these companies. And that ensures us that no matter what, we're getting the maximum bonus money and don't have to deal with, having our funds held up or minimized based on future suits. I walked through the bill, so these slides are here for more detail on kind of the three main features of the bill from last year, but I'll skip them for now. And I believe at this point, I will hand it to Evan Romanoff to talk about this new second wave of settlements and kind of what we're doing this year with the new opioid settlements.
All right, Assistant Attorney General Evan Romanoff, please introduce yourself for the record and proceed with your testimony.
Thank you, Chair and members. My name is Evan Romanoff. I'm an Assistant Attorney General at the Minnesota AG's office working alongside Eric on opioid issues. So Eric's testimony was really focused on what we've done in the past with regard to opioids. These next few slides really go into where we're at now and moving into the future. So as you can see on this first slide, we've now reached 5 additional settlements on top of the ones Eric mentioned with 2 opioid manufacturers, Teva and Allergan, and 3 additional retail chain pharmacies, CVS, Walgreens, and Walmart. And on top of the $300+ million that is coming to the state as a result of the Johnson & Johnson and distributor deals, if we achieve the maximum amount from these 5 settlements, so maximum sign-on or global peace, as Eric referred to it, we stand to gain up to a maximum of $248 million additional dollars. And these 5 bullet points just lay out how those dollars are allocated among the 5 new defendants. So Teva is going to pay about $47 million over 13 years, Allergan $28 million over 7 years, CVS $62 million over 10 years, Walgreens $67 million over 15 years, and then Walmart $35 million, and that will be paid up front, so all within the first year, assuming we can achieve global peace as we did with the last round of deals. So similar to Johnson & Johnson and the distributors, these new settlements are financially structured very, very similarly. There's base and bonus terms, the same provisions as the first wave, meaning that we need cities and counties to join or otherwise have their claims released in order to get that $240 million mark. Also, that MOA we reached with cities and counties in December 2021 and early last year. We're in the process of finalizing an amendment to it to make it applicable to these new settlements. So as it's currently drafted, it only applies to Johnson & Johnson distributors and then a couple bankruptcies with Purdue and Mallinckrodt. So we're now amending it to make it applicable to these new settlements and future opioid settlements, so we don't have to go through this process again every time we reach a new settlement. So we're going to be sending that to local governments very shortly, hopefully this month, and we anticipate that it'll have the same allocation mechanism as the old MOA. Same 75-25 split and same amount intrastate to cities and counties. This is just a really high-level overview of the timeline of where we're at with these new deals. We joined them, the state joined them in December 2022. Last month, notice went out to local governments just informing them of these settlements and that they would have the opportunity to sign on shortly. Later this month, along with our amended MOA, actual more detailed sign-on instructions are going to be going to cities and counties, and they'll have the opportunity to actually join and release their claims. And they'll have until April 18th, 2023 to do that. So that's the participation deadline for local governments to join and release the claims. And then about a month after that, exactly a month after that, May 18th, there's what's called a reference date in the settlements, which is basically a date by which the defendants have to determine whether these settlements actually go forward. So they basically have the opportunity to subjectively decide based on their own criteria whether critical mass has been reached, whether enough subdivisions nationally have signed on in order to go forward with the deals. So if they decide not to go forward with the deals, essentially all the claims that cities and counties released, as well as the state, those are null and void, and litigation can continue. If the defendants have decided that enough cities and counties have joined to go forward with the deal, those releases will become effective, essentially. And then later this summer, we will, assuming that everything goes forward, we'll file our consent judgments in state court here in Ramsey County, and the first payments from these new 5 settlements will begin to flow. So the last substantive slide here is just sort of a question, a placeholder. Like the distributor and J&J agreements, as I said, we need global peace here in order to get that $240 million mark, which we're focused on getting, which means the resolution of ongoing lawsuits and litigation that's been filed against these companies, as well as preventing future claims against these companies. The claims bar in the bill that was passed last year, like the MOA, only applies to the settlements that were reached last year. So there's a potential we could be coming to the legislature with an amended claims bar, basically just expanding it, a really simple fix to cover these new settlements, and that'll be based on whether or not we get enough voluntary sign-on, essentially, from subdivisions going forward. So our last slide here is just our contact information where you can send any questions you have, or members of the public can send questions. We have a website which we will supplement to include additional information going forward. There's also a really great website on the opioid settlements, nationalopioidsettlement.com, which has really helpful summaries, FAQs, graphics, things like that. But I think we stand for any questions.
All right, thank you. We're going to go to our last testifier and then come back for questions.
Sure.
Angie Tice, Child Wellbeing Policy Analyst from the Association of Minnesota Counties. Please introduce yourself and proceed with your testimony.
Good afternoon, Chair Frederick and members of the committee. Thank you very much for having us here today. My name is Angie Tice, and I am the Child Wellbeing Policy Analyst for the Association of Minnesota Counties. I would also like to recognize Representative Baker and thank the Attorney General's Office and our friends at the League of Minnesota Cities and the Coalition for Greater Minnesotas who have been collaborators and partners in this space. As you also beside me, Sarah Wright, who is the current past president of the Local Public Health Association. We anticipated there might be some local questions about how this was operating, so she's here to handle that viewpoint if I do testimony in 2 minutes. So to date, as you heard, Minnesota counties and cities have received approximately $63 million. With 75% of that being directed directly to local government, again, cities and counties. We've remained in, as a reminder, Minnesota is one of 9 states that is state supervised, county administered. So local government, cities and counties are uniquely positioned to and are closer to this work. We respond in a quicker pace. We're a little bit more flexible and can make decisions and work closer with communities and individuals with lived expertise. We remained in really close contact with our commissioners and our local public health association and the Minnesota Association of County Social Service Administrators. And just wanted to cover broadly the categories underneath the MOA agreement. And those are spelled out in treating opioid use disorder, preventions, other strategies. And then there is really a line also on research and premortem examinations as well. Why public health is important is that they were designated as in the role of a chief health strategist in the memorandum of agreement. And so their role locally is really to pull together stakeholders to work within county, human services, public health, and corrections, and within, again, community to establish conversations to really look at what's currently happening on the ground, what are systems and programs put in place, what's working, what's not, and where can we do better. To date, LPHA as an association across the state, we've held 6 learning collaborations across local public health and continue to do that on a monthly or bi-monthly basis, really sharing amongst counties those strategies and the operational considerations in administering these funds. Counties have largely been accessing resources through the Attorney General's office and then also through our national association, the National Association of Counties. And they published, there's a Colorado Blueprint, which is an evidence-based strategy. There's also the Johns Hopkins Principles. And we have access through that collaboration also to SAMHSA for technical assistance and evidence-based recommendations as we think about dedicating these resources. You might be wondering, are these resources actually flowing? So the first payment was received, I think, in October, maybe by Halloween is our latest date. And so counties, there's the theory, and then there's like what actually, hits the check or hits the bank account, and how do we make sustainable and responsible financial decisions. Some of the funding is front-loaded over the first 5 years, but as you heard, most of the funding will carry through over 18 years. And so counties have been taking this time, and cities, I presume, as well, thinking really, how do we plan? How do we engage communities? What are existing advisory councils? Do we need to establish one? Do we need to establish a website? What are the mechanisms by which we make spending decisions? And so over about the last 4 months, counties have been doing that. I have some anecdotal data on where counties are at and ideas that they have on how to dedicate these funds. But I might pause here and see if there are questions.
So I will just say, if Sarah, right, I don't know if you have any testimony that you want to add. If you want to just add something quick, please introduce yourself and proceed with your brief testimony.
I'll just correct the record. My name's Sarah Grocius, but I'm the public health director for Wright County. Angie was trying to speak, obviously, very quickly. And I have been facilitating these conversations, and our county is one of 2 counties that actually had a pilot program to address opioid misuse in our community since 2017 through SHIP, which is the State Health Improvement Plan partnership through MDH. And we've been able to be kind of a little bit of a lead, as well as St. Louis County, on some of this work. So we can talk a little bit about where counties are at, if that is a question.
Perfect. All right, we do have a couple minutes that we can go past time. I will pivot to members' questions at this point to ask questions from either these testifiers or the previous testifiers. Representative Hansen.
Thank you, Chair, and thank you, everybody, for being here today. I just wanted to give a special shout out to Representative Baker and to the AG's office for helping last year in the first wave of the settlement money. There were some delays in my city passing that, and so I'm really excited that we were able to get that through and then therefore increase the whole entire state's funding on this settlement. So my question is, in the second wave of funding, I don't know if the AG's office wants to respond to this or not, but are we going to be notified as representatives earlier if our cities choose to not participate? That was a challenge for us to make sure we could get the right responses. And my second question would be, are you working directly with the cities in a way to help prevent any cities from maybe missing the deadline? Thank you.
Mr. Romanoff.
Thank you, Chair and Representative. Yeah, it's a good question. We will notify cities and counties as those issues come up and as we become aware of them. And to the extent there's any help we can get from members of the legislature, we will certainly be reaching out. We don't anticipate any of those issues, but there may be some that come up. I'm not sure what individual cities and counties might have issues with the settlements. We hope they reach out to us before they decide to hold a city council meeting and vote against joining, but that's always a possibility.
Representative Hansen.
Thank you, and thank you, Chair, for that. Thank you, Chair, and thank you for that answer. I would just ask that you please engage us sooner, as soon as you know that there may be a question or a challenge about this. Our community really had to pull together. Representative Baker came down from a long ways away on a chilly night to make sure we could have that conversation, and it just took some finagling. So I would just appreciate a heads up on that in the future. So thank you.
Representative Baker.
And just real quickly, too, Mr. Chair and others, thanks for sticking around. This is a lot of information today. There's a lot of good work going on in Minnesota, and I'm really proud of that. And again, with all the partners that you've seen here, with Angie, with Sarah, with the folks that are around us, there's a lot of good people. I also wanted to just put out a shout for the Faces of Fentanyl that right now has been set up over at the Capitol. You're going to notice a lot of people that are have lost loved ones. And again, take a look. I think the display will be up for about a week. There will be a I think there's a bit of a program next week on a day. I'm not sure the schedule, I'm sorry, but take a look at those faces. They are people that we love. They're people that are lost. My son is over there too. So just take a look at it. I just wanted to bring the committee aware of that. And the people that are putting this together are just moms and dads, and that's what's happening. So I just want to put a shout out, Mr. Chair, and I appreciate that very much. Tuesday, 10 o'clock. Thank you very much is the program. Thanks.
All right, thank you. Representative Edelson. Oh. All right. With that, there's no other business in front of the committee. Our next hearing will be Monday, February 20th. We will be hearing House File 1627 from Representative Edelson, House File 1198 from Representative Hansen, House File 1114-16 from Representative Kieran, and House File 1566 from Representative Hansen. We are adjourned.